So hi everyone, as I said, this is Kirsty Britton and I'm going to be chairing today. And I'm really excited to introduce Dr. Jennifer Pellowski, who's going to be speaking to us today. She's a social psychologist based in the United States. She's an assistant professor of behavioral and social sciences at Brown University. And she's also an honorary senior lecturer here in the Division of Epidemiology and Biostats at UCT. Her research examines the influence of social context and social position on HIV treatment outcomes and the development and evaluation of interventions to mitigate these impacts. And for the past couple of years, she's been working with us in the community of Guguletu, specifically to understand the transition from pregnancy to postpartum among women living with HIV and how this transition impacts on treatment outcomes. And she's very soon going to begin a pilot evaluation of a community health worker delivered intervention to improve outcomes in this particular population. So Jennie, thanks so much for joining us. I know it's really early in the morning there, but thank you. We're really looking forward to hearing what you have to say.
Great. Thanks, Kirsty. Wonderful introduction. It's a nice foreshadow of many of the things I'll be talking about today. So that was wonderful. So I just wanted to start off by giving an overview of what I want to talk about today. So I do want to talk a little bit about my own overarching orientation and approach to how I think about health issues. I'll spend a very little amount of time talking about the epidemiology of HIV in South Africa, and then spend a lot more time on postpartum retention in HIV care, talking specifically about a longitudinal qualitative cohort that we've completed in Guguletu, and then also talking about all of the science and design decisions that went into developing the RCT that Kirsty had mentioned. Now, I got involved in the HIV epidemic actually in the United States. So we have our star here. I was working, when I was working on my PhD in Atlanta, Georgia. So my PhD is in social psychology, which is really around understanding individuals' behaviors as they are influenced by a social context. And so this could be real or perceived influence of others. This could be influence within romantic partnerships. It could be within family settings or within society. And so when I was working on my PhD, I was very much interested in this idea of social position, particularly as it related to HIV treatment adherence among people living with HIV in Atlanta, Georgia. So this is Georgia, for those that are unfamiliar, and Atlanta is in this northwestern corner. And topics that I was particularly interested in at that time were things like food insecurity and how that related to HIV treatment adherence, as well as education and low health literacy. And really the key here was, how do you develop behavioral interventions focused on those aspects of social disadvantage or social position in order to improve medication adherence and individual level behavior? So for those that might not be too familiar with the HIV epidemic, unlike the South African HIV epidemic, which is a very generalized epidemic, the HIV epidemic in the US is very concentrated among different pockets. So these generally are among sexual minorities, racial minorities, and are clustered particularly around cities, but we also have this band in the southeastern area of the United States, which is a region that also has a lot of different comorbidities or other health issues happening at the same time. So obesity is very high in this region, also lots of hypertension and type 2 diabetes. So there's a multitude of factors kind of occurring among these different populations that are impacted by HIV. So when I was working in the US HIV epidemic, I really was spending a lot of time thinking about this idea of social disadvantage and how that plays out across the lifespan and at multiple different levels. So I present this because it very much reflects on how I approach thinking about HIV research, particularly maternal health and HIV research. And so this is just the first figure from that article, which really thinks about the many factors that engage in order to drive HIV epidemics, right? So we have our biological factors, which are a no-brainer. You also have community level factors, so HIV prevalence within the community, what are the number of detectable viral loads, undetectable infections, and then where I spend a lot of time is thinking about these next two cogs in the wheel. So thinking about the social factors that drive these HIV epidemics, including economic inequalities, substance use, access to care, mental health issues, and then individual risk behaviors. So whether that be sexual risk behaviors in the US, epidemic injection drug use behaviors really tend to drive the HIV epidemic. And you can also put in there, not caring for your adherence, so HIV non-adherence, and how these different factors that operate at different levels are influencing both HIV disease trajectories as well as the different sorts of comorbidities and HIV mortality. This is the last figure I'm going to show from this paper, but I think it's a really nice orientation to the ways in which I think about factors that influence HIV health outcomes. And so I really want to recognize here with this specific figure is both these individual level factors. I'm a psychologist. I am interested in the individual, but there are a number of social and structural level factors that really happen in tandem and influence those individual level factors. And these map on fairly well regardless of where the HIV epidemic is. So if you take the HIV epidemic in South Africa and think about kind of these environmental resources and constraints, we know that HIV is much more prevalent in certain communities than others. And we also know that stigma and discrimination within these communities can have a substantial influence on whether or not, in this case, women access care or engage in medication and treatment adherence. So one of the factors I wanted to just spend a little bit of time with is when we think about all of these factors, both individual, social, structural, and then across the life course, it really takes an interdisciplinary approach in order to understand both how these different factors operate to influence health, and then also how to mitigate that risk. So intervention work is something that's very much a core to what I do, and recognizing, okay, it's not enough to just study what's happening, but how can we do certain interventions. I focus on behavioral interventions, but you could also think about clinic level interventions to mitigate these different risks. So it really does take a village, and not to say that I personally employ all of these approaches, but I do borrow from certain aspects and then also engage with experts in these fields in order to better represent what is happening in these communities, and then also contributing to improving health outcomes. So as I was finishing my PhD, I was very much focused on, learning new skills and also creating the greatest impact. And so, no surprise, South Africa has one of the largest HIV epidemics in the world. And I had some connections at Brown University where I did my postdoc already in Cape Town in particular. So that's what brought me here. And I just absolutely fell in love with both the people and the context in order to understand particularly women's health. So women's health is something I had also been really interested in, but in terms of the HIV epidemic in the United States, women are actually less likely to become infected with HIV compared to kind of the South African epidemic. And particularly when you think about pregnancy and maternal health, it's not as a core issue in the HIV epidemic in the United States. And so these are things that I really wanted to get involved with and learn more about. And so that brought me to doing a lot of work in South Africa. So today I will be focusing specifically on my work on HIV and maternal health, but I also do some more broad maternal health work as well that I won't be talking about today. So no stranger to any of you, South Africa does have a large HIV epidemic. The adult HIV prevalence, these data are from 2017, but that estimate was around almost 19% of the adult HIV population. South Africa also has the largest ART provision program. However, there still is a gap in the percent of adults and children who are eligible for antiretroviral therapy actually receiving and continuing on that treatment. In the South African context, you also see these large gender disparities in HIV prevalence. These data are a little bit old, they're from 2012, but what we see from this graph is really particularly among young women, as well as kind of adolescents and young adult women, really the key reproductive years are when people are starting to have children. We see large discrepancies in HIV infection compared to their same aged counterparts. So there are huge gender disparities, and these persist although across the lifespan, although the error bars do overlap. But really, in particular, from around 15 through definitely the late 20s and into the 30s, you see these large discrepancies. And when you look at HIV in pregnancy in particular, these are data from public clinics, antenatal clinics. You see high prevalence rates as well. So in the community, Kirsty mentioned working with their team in Guguletu has around 26 to 30% HIV prevalence in those antenatal clinics. And obviously there are huge disparities across South Africa. So in KwaZulu-Natal, you have much higher antenatal prevalence rates across the country. So one of the things to really mention when you're thinking about HIV in pregnancy is that there are actually quite a few positives. So in terms of prevention to mother-to-child transmission efforts, including option B+, vertical transmission rates have dropped dramatically in South Africa. So this is just one estimate of 2.7%. In some areas, it's much lower, such as the Western Cape. Sits around, I think, 1.2%. However, there are still gaps that exist. So women who are living with HIV are 8 times more likely to die during pregnancy and postpartum than women who are HIV negative. And we see this disengagement from care by 6 months postpartum. So this could be, just starting to miss a care appointment or disengaging from care completely. And so from some of our own work, so these are some data from the Drakenstein Child Health Study, in which we looked at, among the women living with HIV, what were kind of adherence to some of the PMTCT interventions. And so what we found in this particular sub-study was that despite these low transmission rates in the Western Cape and what we found within the cohort, what we found in the cohort was actually even lower than the Western Cape estimates. There are still areas for improvement, particularly for PMTCT. So from this study, we found retesting at-risk HIV-negative mothers throughout the duration of breastfeeding was a serious need. infant HIV testing at any hospital or clinic admission, in addition to those routine testing, is needed in order to eliminate mother-to-child transmission. And then we did find about 25% of women had defaulted from treatment during pregnancy. So there's this increased, this recognition that we need improved counseling in order to prevent that defaulting during pregnancy in particular. So when I was starting to do work in South Africa, this was actually an article that I came across that really solidified things in my mind, which is this article by Christina Pissarros talking about falling off the cliff of the treatment cascade. So thinking about women's health after pregnancy. So in the Option B Plus era, women are on treatment for life. And so women are supposed to, typically they start during pregnancy if that's when they've been diagnosed, and will continue on through pregnancy and then through postpartum for the rest of their life. But some studies, and I should mention, this is from 2015, so there have been a couple more studies since then. But what Christina Pissarros finds is that while some studies have examined adherence to postpartum PMTCT guidelines, few focus on continued engagement by the mother, and very few examine adherence beyond the 6-week postpartum visit. And so that's what really sparked my journey on this 5-year project, which was thinking about this research need, right? So needing to identify when and why women are becoming non-adherent non-adherent to antiretroviral therapy, and may drop out or disengage from care during this transition from pregnancy to postpartum. And also to understand how influential factors may change as women are experiencing this transition from pregnancy to postpartum. So that's what sparked my KO1, which is a 5-year grant. And so what I'll spend a lot of time focusing on today is actually aim 1, which was to identify contextual, interpersonal, clinic, and individual level factors that influence women's treatment adherence, specifically during key points of transition. And I'll come back to this kind of key points of transition piece during the transition from pregnancy to postpartum. Aim 2 is to evaluate the feasibility and preliminary efficacy of a theory-based ART adherence intervention, specifically for postpartum women. And so Kirsty has alluded to that we'll be launching this study soon, but I wanted to show some of the research and data that went into the design of that study. And then the third aim, which I won't talk about now, is post-trial, asking participants about their experiences and identifying ways to refine the intervention for subsequent evaluation. So I'll spend quite a bit of time talking about aim 1, which was this longitudinal qualitative cohort. So the goal of this was to recruit and retain 25 to 30 pregnant women and follow them up to 12 months postpartum. And so we conducted 4 interviews with 30 women, particularly focusing on what I had mentioned as kind of key points during the time postpartum. So we wanted to capture kind of their experiences during pregnancy and any anticipation of issues that might happen postpartum. So we enrolled and did the first interview with women during their 8th month of pregnancy. And then we followed them up and conducted a second interview around 6 to 8 weeks postpartum. And what we wanted to capture in this second interview was thinking about reflecting on their labor experiences and also their early experiences with their new baby. And I should also mention, we did not restrict to first-time moms or women that were newly diagnosed. We took a kind of all-comers approach in order to get a sense of the different diverse experiences that women have across this transition. The third interview occurred between 4 and 6 months postpartum. And so this was really focused on some mothers might be transitioning from exclusive breastfeeding to introducing food. Some women might be transitioning back to work at this point and how that might influence how they engage in care. And it's also trying to capture some of those early results of the HIV tests among their babies. So women receiving the results of their initial infant tests. And then the final interview occurred 9 to 12 months postpartum. And so this was really to understand kind of later out postpartum when they have a much more active infant. If they are going back to work, likely they have already gone back to work. Trying to capture any dropouts from care or any issues that they had along this entire continuum of these postpartum months. So being able to reflect back on that entire year postpartum. So I don't want to spend too much time on this, but transitions theory is the theoretical framework that we used to both guide picking of the time points as well as our general orientation to the study and the interview guide content. So I just want to point out a couple pieces about the theory, which is this theory posits that there are certain transition conditions that are facilitators or barriers to engaging in a successful transition. And a successful transition in our minds are both a successful transition to motherhood and then also successful transition in terms of engaging in care in the postpartum period. So women in this context will receive their antiretrovirals from the midwife obstetrics unit, but will be transitioned to a general ART clinic or a baby adult clinic in order to receive their ARVs. So they have this care transition that occurs in the postpartum period as well. And so kind of echoing what I started with, which was, focusing on individual level factors and also thinking about the social context. So at the individual level, we were very interested in personal meanings of motherhood. What does it mean to be an HIV positive mother? What does it mean across the transition? Thinking about individual cultural beliefs and attitudes, socioeconomic status, and then preparation and knowledge. So this was particularly in the pregnancy interview, how they're anticipating life changing, how are they preparing, do they feel like they have enough knowledge and education in order to make that transition. In terms of community, I often feel like this is mislabeled because it's really talking about an individual's close community. So thinking about partnerships as well as close family members, so that smaller community. And then this society is really talking about the broader community. So thinking about broader community and society, how their communities view women living with HIV, pregnant women, and how that might influence an individual behavior. So things like stigma or discrimination within the community. So as I mentioned several times, we operate out of the Guguletu Midwife Obstetrics Unit for this study. And we ended up enrolling 30 women. The age range between 20 and 41. So we did actually have a couple women who were on the older end of the spectrum. About a third were first-time mothers. Again, a little less than a third had completed their secondary education. And I just want to point out here, so this is a self-reported ART adherence. So this is using the VAS, which is the visual analog scale, which is just a number line. Women report from 0 to 100 where they fall in terms of adherence for the last month. And so what we found was, obviously it's self-report, so there is a certain level of social desirability, 92, almost 93% adherence during the past month. So that is a pretty good adherence rate. So I'm not going to spend too much time, or I'm going to try and go through quite quickly the interview some of the main findings from the pregnancy interview. And these are mostly just like snapshots of what we were finding from these interviews, not necessarily a thorough analysis. But what we did find was, coupled with that high level or high rates of self-reported adherence, is we did find high levels of motivation to be adherent. So this, the interview is asking, all right, do you think this may change or not after the baby comes? What do you think? And the participant says, are you referring to treatment? Yes, being on treatment. And the participant says, it can't change because if I don't take treatment, who will be looking after my baby if something happens to me? I can't risk my baby's safety and well-being by neglecting myself. And this was a very common sentiment among women, which is feeling that taking treatment was intimately tied to the well-being of their baby, and that neglecting their own health would influence not only fetal health, but also their baby's health postpartum and their baby's safety. Employment and financial concerns came up among many women, thinking about this idea of not wanting to be a burden to family members and wanting to be employed in order to provide for their children. So the interviewer says, why do you want to work? And she says, I don't want to be a burden to my mother. How? I don't want to depend on her financially. I want to buy nappies and clothes for my baby out of my pocket without asking money from my mother. So this was actually a very common sentiment among mothers, is this idea of wanting to be self-efficient and or having the capacity to provide for her child financially. There are a number related to these financial concerns and thinking about employment postpartum. There were a number of logistical concerns that came about in relation to that. So this particular participant mentions, another challenge will be getting a job, which will force me to look for someone to take care of my baby. I will have to express breast milk, and whoever will be taking care of my baby might feed him not as I would do it when I feed my baby. And the interviewer says, who might take care of your baby if you get a job? And she says, my mother. And so there's a number of factors in here, which is trying to find childcare that is either with a family member or paying for creche, how to afford that. And then there's also this, for moms that really want to exclusively breastfeed, thinking about all of those logistical pieces in terms of, how am I going to express breast milk when I'm at work? What if my caregiver feeds my baby, either formula or starts to give my baby porridge when that's not what I want. So there are a lot of different concerns about how do I make, I don't want to be a burden. I want to have a job, but that also is coupled with trying to figure out the logistical pieces to making that happen. Women also mentioned several worries about baby. So this was a little bit less common, but just as one example, the interviewer says, what are challenges you think you will face when baby is born? Since you mentioned that your sister-in-law will take care of the child, what are some challenges you will face having your child growing in another place? And the participant says, not seeing my child every time. I will not be able to read my child properly because the child will be growing up away from me. Also, the child will not bond well with me. And so this is one example of a woman who was bringing her child to the Eastern Cape. And while we did have several women that did do that, this sentiment also comes through just in terms of, if a woman is working, not being there all the time, seeing their child. So it's this tension that exists as well in terms of wanting to be there for the child, wanting to bond with them, but also wanting to provide for them as well. And then finally, some participants did mention concerns around engagement in HIV care postpartum, not quite understanding where to get treatment postpartum. And then this quote is particularly around forgetting treatment once baby comes. So the interviewer says, all right, what will happen when you forgot to take treatment for a number of days when the baby is born, as you just said to me? You don't have any other strategy? And the participant said, that would be stressing me if I don't take medication at all. I will relapse and it will be difficult. I have to make a plan to have something to remind me to take treatment when the baby is there. That is the only thing I can do. And she goes on. Sometimes the baby can keep you busy, and that's when you forget to take treatment. So she's already anticipating that there might be some times when she's caring for the baby and might forget her own needs, and thinking about, okay, what are some of the strategies, not necessarily knowing what those strategies might be. And I should also mention this point at the bottom, which is many of the barriers that women predicted during pregnancy were largely the barriers that they experienced or were still anticipating that they would experience postpartum. So women are very good at anticipating what those issues are going to be in the postpartum period, or what are those big factors that are going to influence how they engage in care. So the next step, so I present data on the pregnancy interview. So what we are spending a lot of time on right now is thinking about how to analyze data longitudinally. So this is an article that was just accepted, which is very exciting, in the International Journal of Qualitative Methods. I'm the senior author on this, which is thinking about the different methods to analyze data qualitatively, longitudinal data qualitatively. And so what we're working on now is something called a framework analysis, which is, I give an example table here. It's this multi-step process in which you think about the themes that exist among participants over time, and then work to collapse those data by participants and by themes to really try and understand trends in change across time, or lack of change, as we are starting to find, in order to make sense of a lot of qualitative data. So I just want to give you just a brief flavor of that analysis. We're still finalizing it. But this is just one example when we're thinking about socioeconomic status, which includes financial support, education, and employment. So from time 1 to time 2, the source of women's financial support, whether that be her partner or her family, largely didn't change during the transition from pregnancy into that. Remember, this is very early postpartum, 6 to 8 weeks. Nor did their financial situations or the particular challenges they were facing change. And while women who desired to return to work or school during pregnancy still desired to do so, the timelines for returning to work often shift. So in most cases, women push that back, but among some women, they actually wanted to start work earlier than they had originally planned. And just to give you another little snapshot, when we're talking about the theme in terms of women's personal meanings of motherhood and how that relates to adherence. So while many women adhered to ART during pregnancy, at least in part for the purpose of protecting their fetus from HIV, it actually seemed like this feeling appeared even more pronounced during postpartum for many women. So this sense of, I need to take antiretroviral therapy to protect my child. And so this is both in terms of if women are exclusively breastfeeding, protecting their child, as well as just this general sense of wanting to maintain healthy life and maintain health for this new child, and to be there in that child's life. And then finally, for some women, especially the first-time mothers, remember we had about 1/3 of the sample were first-time moms, transitioning into the postpartum period meant becoming more selfless and prioritizing baby's needs over their own. So there is this expressed change that happens in which women talk about being more selfless, whether that's both talking about needing to prioritize baby's health or actually demonstrating that selflessness. So in terms of kind of future directions, obviously, we have a lot more data analysis to go. We're finalizing the time 1, time 2 data, and we'll also be looking at across all 4 time points. I'll talk a little bit about this K01 phase 2, particularly as it relates to the design of this biobehavioral randomized control trial. But I also wanted to just talk a little bit about a kind of side project that came out of this, which was thinking about women that are both living with HIV but also diagnosed with pregnancy complications. So we got some money from the Providence Boston Center for AIDS Research, CFAR, in order to understand women's experiences of dual diagnoses of pregnancy complications and HIV during the pregnancy period and how that influences postpartum follow-up care. So that is a study that is actively happening now. So turning to designing the behavioral randomized control trial, the main question I started out with was, what are the necessary components of a behavioral intervention that can address the many needs that these women have? So I noted some that came through in the pregnancy interview, but typical behavioral interventions can't necessarily address all of those factors that women were discussing. So there are 2 sources of data that I used in order to inform the design of the study. So the first is a meta-analysis, a literature synthesis that led to a meta-analysis, and then also some data from our time 4 interviews. So this systematic review and meta-analysis was published in, I want to say, 2019. And included, we screened almost 6,000 abstracts, and inclusion criteria for this meta-analysis were that they reported on a behavioral art adherence intervention tailored for cis women living with HIV. So we actually didn't restrict it to among pregnant and postpartum women, and I'll get to that in just a second, but we're focused more on just women in general. The outcome had to be art adherence, or art adherence had to be one of several measured outcomes, had to employ a randomized control trial or gold standard design, and then have enough data in order to calculate effect sizes. So ultimately, we ended up with 16 studies in the qualitative synthesis, and then 13 studies had enough data for the meta-analysis. So for those that might not be super familiar with forest plots, so this is reporting effect sizes using Cohen's d, which kind of general rules in terms of Cohen's d. A Cohen's d of 3 would be kind of a small effect size, 0.3 small effect size, 0.5 is around a moderate effect size, and 0.8 is around a large. There's some variability in there, but those are kind of general guidelines. And so what we have here is what we note here is effect size of 0, meaning that the intervention, there was no difference between the intervention and control. Negative effect sizes indicate that there were larger effects, or that the control condition had a greater impact on art adherence than the intervention condition, and positives indicate that the intervention condition had a greater impact on art adherence compared to the control. So what you'll notice about this forest plot is it actually looks very skewed. So you have two studies that have massive effect sizes. 5.8 is on a Cohen's d is a massive effect size, but most of the effect sizes are actually very much pooled around 1. So the mean effect size when you take all of the effect sizes together is 0.82, which is associated with a large effect size. However, when you actually take out these 2 studies, this drops down to a 0.2, or a very small, non-significant effect size. And so I also want to just note The majority of these studies were not with pregnant and postpartum women. So we only had 2 studies that were with pregnant and postpartum women. This Messersmith article, and then this Sarna article as well. So these are both studies with very small effect sizes compared to some of the other studies. And so because there was substantial variability, we were able to look at moderator analyses. So these are moderators of the effect size. And I just want to point out a couple things. In terms of trying to get at components of studies that we could use in terms of informing designs, we did find that having a group component of the intervention did lead to significantly larger effect sizes. So, I mean, it's right on the border there, but it is significant, to significantly predictive of larger effect sizes. And then on this table, again, not a lot of things were happening in terms of components of the intervention, but one of the things that did show up is this idea of alteration of the healthcare system. So let me go to the next slide. So the way that we defined kind of alteration of the healthcare system was very broad. So it actually only included 2 studies, and one of those studies looks at task shifting from doctor-centered care to nurse-centered care. And then the following, the second study used community counselors in order to kind of alter that healthcare system. So these are the main takeaways in terms of intervention development. And I just want to take both of them in tandem, or each of them at a time. So when we take alteration of the healthcare system and think about our context, task shifting from doctor-centered care to nurse-centered care actually doesn't make sense for our context, right? It's already a midwife obstetrics unit largely led by nurse-centered care. So that led to thinking about community counselors and how to engage community health workers in particular. So when we think about kind of those main themes or main findings that were coming out of the pregnancy interviews, we can think about how community health workers can work to address some of those issues. So in terms of high adherence motivation, really that's an excellent strength of these women. And so the role of the community health worker would largely be to bolster that motivation and keep encouraging women. In terms of employment and financial concerns and logistic concerns, this typically would be very difficult in a traditional behavior focused intervention. So how we've conceptualized it is that a community health worker can provide referrals to both governmental or community resources, as well as engaging in motivational interviewing to help women essentially identify the steps that they would need to take in order to overcome some of these financial concerns. And again, provide some counseling around, strength-based counseling, where identifying the strengths that exist within these women's own lives and their own capacities. In terms of worrying about baby, this can be addressed through kind of basic low-level health counseling. And then in terms of confusion about how to navigate care in the postpartum period, both kind of where to go as well as engaging in our adherence, we can think about navigational support when needed, right? So the community health worker having a better idea of where these women might be transferred to and helping them through that navigational process. So going to the group component, we were very interested to see what women would say about that. So we actually asked them explicitly in our time for interviews. So again, this was 9 to 12 months postpartum, and the majority of women did talk about, did provide support for the group component, right? So I think participant 130 is really indicative. So she says, I would choose the one that includes all mothers because I would hear different views and challenges. Maybe we might talk about experiences that we couldn't handle in our lives, but I would learn how to tackle them in the future. I would get to learn more about their different challenges. I would enjoy being in a group. So she talks about the importance of this group component to really hear from others and to get a chance to connect with women like her and ones that are dealing with different challenges or maybe dealing with the same, and how, you know, talking in a group setting, you can learn a lot from your peers. So this leads to our behavioral intervention design, which is comprised of this multi-component intervention. So it's coupled with one-on-one meetings with a community health worker, 4 of those during the transition from pregnancy to postpartum, and also small group discussions with other participants, again, mapping onto the pregnant postpartum transition. So this was our original design, and we were expected to launch in March 2020. Unfortunately, we were unable to enroll any participants and have been on hold essentially since then. So pending COVID-19 related approvals, we're looking to launch potentially in October, but we have made the decision to take out the group in the current context of the COVID-19 epidemic. We do hope that we'll eventually be able to add that back in a larger trial. So for example, like a 3-arm trial in which you have a control intervention that's just the community health worker intervention, and then another arm that's the community health worker intervention plus these small group discussions. Because women really did talk about how they would really like it, and it would be important in terms of connecting with others. So that is the goal going forward for that. So stay tuned in terms of the preliminary efficacy and feasibility of that study. So just to summarize very briefly around HIV and pregnancy. So pregnant women living with HIV in this particular context, right? So in the Googlet, or recruited from Googlet to MOU, are faced with a number of barriers that they are able to anticipate, including employment, financial issues, logistical issues, worries about their baby, and HIV care concerns. And interventions in the literature with both group components and those that alter the healthcare system in some respect do show greater improvements in our adherence as an outcome. And these components are further supported by that formative qualitative work as being something that participants would like and would find value in. So with that, I just want to kind of bring it back to this idea of transdisciplinary approaches. So I hope that I've demonstrated some ways in which, you know, I've tied psychology to things like epidemiology and clinical science in order to better understand the needs of women and also to design interventions to mitigate poor health outcomes among this population. So with that, I just want to acknowledge the village of people that it's taken to be able to do this work, particularly Zanelle Rini, who did all of the interviews with our women and has just been absolutely spectacular. I also have a research group at Brown, students that have been analyzing the qualitative data, and of course, a wealth of really smart people at University of Cape Town that have really helped me in my personal journey as a researcher, as well as getting the research done. So this is just a picture of Zanelle, who we really love. And I'm happy to field any questions that people might have. Let me stop share, I guess.
Jennie, thank you so much for that really great presentation. I'm going to open it up to questions because you and I chat multiple times per week. I do have a question, but I'm going to see if anyone else does before I go ahead.
Great, perfect.
So if you want to just raise your hand if you do have a question for Jennie. I'm not seeing any hands, so I'm going to ask a question. So Jennie, something that we've probably spoken about a lot, but I think warrants being said again, is sort of how important the person delivering the intervention is, and sort of thinking about the characteristics of this person and what, you obviously want the best possible person delivering the intervention, but also thinking about if this intervention were to be rolled out at scale, and how do you ensure kind of that you've got the best possible people while still making it feasible at large scale.
Yeah, definitely. And it is something you and I have talked about, but, I've spent quite a bit of time thinking about. So in terms of, my tradition is in behavioral intervention development. And oftentimes those interventions are, the actual person conducting that intervention is a PhD level psychologist or a master's level psychologist. And so in this particular setting, we do want to pay a lot of attention to, we want this to work, right? If this works, thinking about that scale up. And so that is one of the factors that I didn't mention in terms of, why do we choose community health workers as the professional delivering the intervention? And the idea behind it is really that all of the things that we want that person to be able to do, a community health worker with appropriate training should be able to provide that assistance. So in terms of scalability and sustainability, that was very much at the forefront in terms of what type of provider to focus this intervention on. And then the other piece of this is the training, right? And so this is an area we are now kind of dipping our toes into, and we'll see how this goes, but being very intentional about the training that occurs. And one of the things that's so important is a sense of empathy among the interventionist. So having an interventionist that is able to connect with women on their level, make women feel very comfortable to be able to talk through the issues that they're facing is so, so important. And so one of the things I'm actually spending a lot of time now as we're, gearing up for launch of this trial is thinking about those training materials and also how to make those training materials more accessible to larger audiences. So not necessarily, so how do you model those training materials so that they can be used among a broader swath of community health workers? And so it's definitely at the forefront of my mind right now, Kirsty. So thank you for that question.
Thanks, Jenny. I see that Steve Reed has a question for you.
Yeah, thanks, Jenny, for an excellent presentation. What you've just said makes me think of two projects that concern the positionality of the intervention, the people involved in the intervention. One is Mothers to Mothers to Be, and the other is the Mentor Mothers program in Pilani, both of which I'm sure you're aware of. And they are excellent examples of people who have been through that experience, really making a measurable difference, and that difference has been measured multiple times. So going on from what you've just said.
Yeah, absolutely. And I think those are excellent models, thinking about the peer support types of models. I think what we were interested in, thinking about community health workers as just another method of doing many of the things that Mothers to Mothers does in terms of navigational support, but through a healthcare professional, and how might that look different, and what are the types of supports that may be different than those types of models. So thank you so much for that piece. And there's a wonderful amount of work that's already happening in South Africa around these issues. And I think the more ways we can have, the better, honestly, because there are a lot of women living with HIV that could use support. So thank you, Steve. Appreciate that.
Thanks so much, Jenny. Are there any other questions? I'm not seeing any other hands being raised. No. Well, then just to say, Jenny, thank you again. I know it's really early your side, so thanks for joining us this early and for presenting your really great work. And I'm really excited to see the results coming out of your pilot trial and to see where this work goes from there. So thank you everyone for joining and enjoy the rest of the day.
Thank you all.
Thanks, Jenny.
Yeah, thank
Bye.
you.
Thanks, Kirsty, for sharing too.
Bye.
I'm going to stop the recording, actually. That's what I'm going to do.